Hello, welcome to JAMA Network Open Live. This is the first COVID-19 televersion of JNO Live, so thanks for joining us. I'm Seth Truger, Digital Media Editor at JAMA Network Open. With me as always.
I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along live, send us your questions and comments on Twitter at JAMA Network Open or in Facebook or YouTube in the comments section underneath the video. We will do our best. Of course, this is our first work from home session, so the technology is a little different. We will do our best to keep up, and hopefully Skype doesn't crash on us. I'm very excited to have our first guest today, our first teleguest. Angel and I are also remote. So the paper we have is Factors Associated with Mental Health Outcomes Among Healthcare Workers Exposed to Coronavirus Disease 2019 by Lai et al., I think is the correct pronunciation. Unfortunately, the authors are in China, and we were able to get the author of the invited commentary, Dr. Roy Perlis, who's also an associate editor at JAMA Network Open. Dr. Perlis, welcome. Thanks for joining us.
Thanks so much for having me. I'm from Mass General Hospital and JAMA Network Open. Want me to say a bit about the paper to start?
Yeah, give us the rundown. What what's the driving force behind this paper? Why do we care about it? What do they do?
Sure. So this paper came to us about a month ago, a little less than a month ago, again from Lai and colleagues in China. And what the authors did at the end of January, beginning of February, so basically over a 4-day period, conduct a web-based survey of docs and nurses battling the COVID pandemic. So the majority of the folks they surveyed were actually in Wuhan, and then about another quarter or so in Hubei province, which was also sort of one of the initial affected regions, and then another quarter or so in the rest of China. And what they were interested in understanding was, first of all, what was the prevalence of symptoms of anxiety and depression and distress among the folks on the front lines? So I think the first goal was just to characterize what sort of symptoms were these folks in the midst of battling the pandemic experiencing. And then secondarily, they wanted to understand what were the factors associated with greater risk for experiencing symptoms among these healthcare workers. And I have to say, when I first saw the paper about a month ago, I knew it was going to be important. But frankly, when I wrote the commentary, didn't really occur to me just how relevant it would be, not for our colleagues in China, but frankly for our colleagues in Washington and New York and here in Boston. And so I think actually with time, the paper's just become, if anything, more important because, again, even though it was done in a 4-day survey and about a week to analyze their results, it gives us the first good look at what are the likely consequences of being asked to battle this virus, frankly, in a setting where no one's especially prepared to battle it. So people will recall, as is the case now in the U.S. at the beginning of the pandemic in China, the frontline workers there also didn't necessarily have access to the equipment that they needed and the preparation that they needed. So the punchline from this paper is that about 12 to 15% of the docs and nurses they surveyed had what we would consider moderate or greater symptoms of depression, and about 12 to 15% had moderate to severe symptoms of anxiety, and then about a third of them had at least some degree of insomnia. So that's part one. So right in the midst of fighting this pandemic, they were pretty profoundly affected. The other thing we need to talk about, though, is that they were also given a measure of sort of psychological distress, how they were responding to the event. And the most concerning thing about those results is that about a third of the respondents described symptoms in a range that has been shown to be associated with post-traumatic stress disorder. So while that doesn't mean they're all going to develop PTSD, it's a reminder to us that beyond the acute symptoms that people may experience, we need to be alert for the downstream consequences. And of course, this is consistent with what we know from the SARS epidemic of years ago, but also from our own experiences in the US with other kinds of traumatic events.
Yeah, it's really interesting. I think one of the things that resonates to me is how easy it is to, in a complex crisis like this to just look at the kind of top numbers, like what's the mortality rate, what's how many people have died, how many people have the disease, and that I think it's those kind of summary stats can underestimate the impact in so many different ways. Even looking at things, how many physicians, how many healthcare workers end up getting infected or end up in the hospital, but things like ICU beds, things like the totally indirect things like people with appendicitis who have trouble accessing care when the healthcare system is overwhelmed. It's just so hard to capture how much the multiplier effects happen. And I'm a frontline worker during this epidemic. It hasn't, we're starting to ramp up here in Chicago. It hasn't gotten completely off the walls yet. But I just the level of anxiety all the time that's just in the department. That everything's on edge, even though things haven't really turned the corner yet.
So, and, we should emphasize that, it's certainly not only healthcare workers that are experiencing the anxiety and the stress associated with the pandemic, right? I mean, one of the things that the reviewers noted for this paper, and that I think is important to highlight, some of what these docs and nurses experienced probably doesn't necessarily have to do with providing care as much as their own sort of personal threats from the disease, right? Being under quarantine themselves. And so, this is a snapshot of what's going on with healthcare workers, but we can't lose sight of the fact that everyone to varying degrees is experiencing this as an incredibly traumatic event or set of experiences.
Yeah, that's a really good point. That reminds me of the probably apocryphal quote from Paul McCartney that the Beatles didn't get to experience the Beatles. And healthcare workers, we're people too. We're citizens here, and yeah, it's kind of you basically did a good job of turning what I said around. That it's not just the impact on healthcare workers. It's we're also normal people. We're citizens during this time period, and there's also the mental health outcomes of the general population. I'm sure is impacted in some way.
And I think that's it's a really critical point that quite rightly people are pointing at the folks on the front lines as heroes, right? I mean, it's heroic, especially when you don't necessarily even have the tools that you might want or the resources that you might want. It's heroic to go fight this on the front lines. But folks like you go home and leave the emergency room and leave the ICU, and you're also people and need to recognize that you can't be a hero all the time, and that it does take a toll to go and fight this. And I think what I've heard from colleagues is they actually feel fine when they're in the midst of it. So when they're at work, they're doing their job. We know as physicians, we know what to do in an emergency. It's when you get home and you start worrying about yourself and your family and your colleagues who are still at the hospital that that you can start to notice sort of what a source of stress this is.
Oh yeah, wow, that really resonates. It's so easy to go to work and just shift into that gear and compartmentalize. Wow. The shifting gears a little bit, we've got, speaking of which, we've got Jyoti Pathak has joined us. Welcome. And we've also got a question from the crowd. Did the researchers study differences by provider type? For example, emergency docs versus psychiatrists offering telehealth services. Can you speak to that at all?
It's a great question. So this particular paper made a distinction between sort of what they called frontline or first line workers and second line, where frontline was really folks taking care of COVID patients directly, and second line were folks who were in the hospital working, but not necessarily providing face-to-face care. And the frontline folks were certainly at greater risk, not surprisingly. This particular paper doesn't break down provider type except to distinguish between nurses and docs. And in general, the nurses were more symptomatic. And, given the sample size, they can't really get into why that might be. There were some differences. The nurses tended to be younger. There were some other differences, but it didn't look by provider type. I think that's going to be an important question.
Yeah, that's interesting. I mean, based on the experiences that I've had so far, I probably spend less time with actual face-to-face contact with the patient than the nurses do. And it's also easier for me to be a little bit farther away. I'm not, the generalist, the nurses doing the swabs, nurses giving medications. I think we're all doing what we can to minimize contact, trying to make sure all the labs that we're ordering are ordered at the same time and not going in different batches. Or we've done some creative things as far as medication dosing or I've seen some interesting comments from, say, ICU pharmacists talking about doing, trying to find, if you're treating for pneumonia, choose antibiotics that are Q24 hours instead of Q6 hours. Creative stuff of using longer tubing and putting dialysis machines outside the room, things like that have been interesting.
So it's interesting. There was one other distinction that they made looking at seniority of the providers. And what they found was that the folks at greatest risk were the sort of mid-career or middle experienced clinicians, which was initially a little bit puzzling unless you think about the literature that shows, in general, the longer you practice, often the more resilient you may be in general, the more confident you may feel. And I suspect for the most junior clinicians in this study, they were maybe getting some protection. They were maybe being a little bit more sheltered. And it was the folks just above them, right? So think of this sort of senior resident, chief resident versus intern distinction, where that sort of middle group that seemed to be under the most stress and experienced the most symptoms. So that probably has something to tell us in this. Obviously, we need to take care of everyone, but we especially need to take care of the folks who may be the most vulnerable, who are balancing sort of the most responsibility, clinical contact, maybe at an earlier stage in their career than they otherwise would, just because all of these systems are so stretched.
Mm-hmm. Yeah. Also, and I'm totally speculating here, but maybe a little Dunning-Kruger, where the total juniors have a confidence that may not be warranted, whereas the intermediates might have enough experience to know how bad things are or how overwhelming things could be. Also, Tam Law has joined us. Welcome.
I actually had a question. It kind of alludes to something that you were mentioning before, but we know that, the current situation in COVID-19 is certainly an extraordinary event, but we do have some points of reference thinking about SARS or H1N1. And I wonder if, in terms of the feelings of anxiety and depression that, the authors note in this paper seem to be on par with what's occurred in the past, or if it's too different to really be able to be comparable.
So qualitatively, I think the magnitude of symptoms is probably similar. It is difficult to compare directly. One of the important things to realize is that while we know a lot in psychiatry, or there's a lot of experience in studying traumatic events, this is really a different kind of traumatic event than a lot of what has been studied. So our focus has often been on a single acute stressor, right? Something terrible happens and we respond to it. And the pandemic is much more akin to, some of the epidemics you describe, but frankly also wars. So there is a literature looking at the consequences of being in the middle of a war or being a refugee, where it's not a single stressful event. It's this sort of chronic stress punctuated by moments of more acute stress. So I think we do have some precedent to try to understand this. One of the things I think is important to emphasize is we do have some understanding of how to respond to these kinds of events. and what works and what doesn't. One of the reasons that I think this paper is so important is there's been a lot of discussion about how you take care of yourself. There's actually the CDC website has a very nice sort of synopsis of, ways to manage COVID-related stress. But the reality is there are some people where the strategies for taking care of yourself aren't going to be sufficient. And so absolutely exercise, talk to people, engage with your supports. Those are all important. But we have to recognize that there will be people where their symptoms aren't necessarily well controlled, where their experience of this event isn't necessarily something that they can manage on their own. So I think the other message that's important to take away from this is for a subset of people, they'll have significant anxiety or significant depression and probably need to look for some help for those symptoms. And again, I think we're at the point in the conversation where we should acknowledge, absolutely take care of yourself, do the things that you can, but also realize that there for some people there will be a need for additional help.
Yeah, and I thought, I really appreciated the point in your commentary, in which you talked about a study that was a 3-year follow-up after SARS, and it showed that there was a certain percentage, I think it was 23% of providers continued to have, I don't know if it was providers or if it was sort of all comers, but continued to experience depressive symptoms even after that, sort of those events. I think it makes sense that it's just like a situation that it's not going to be a one and done. It's something that we're going to have to be dealing with for a long time.
You make a great point, and that paper, which did look at providers, was in my mind when I wrote the commentary, because my fear was that, at least in China, the acute crisis would subside and the world would move on, and there would be this whole population of physicians and nurses and others who were horribly traumatized, who maybe didn't have access to the resources they needed. Now, obviously, in light of recent events, what I was worried about in Wuhan is absolutely something we need to worry about here in the U.S. as well. And so, these heroic folks who are out there taking care of patients on the front lines, we can't forget that a year, 2 years, 3 years from now, there probably will be consequences for at least some of them.
Yeah, well, one other thing I want, that's just really important. I think your point that just how much, we're recognizing there's consequences, we're recognizing the burden. We need to, there's things we can do. I think that's the as Andrew will appreciate my optimistic takeaway. It's not, this reminds me of a conversation I have with patients with concussions, where we know the burden is bad. We used to be really bad at recognizing it. Here's all the reasons why it's scary, but hey, good news, we're getting better at recognizing it and plugging people into care.
This is probably the point where, even though I'm a psychiatrist, I should look at the camera and say, if we got them some damn masks and tests, that would also go a long way towards managing the acute and the long-term consequences, right? I mean, we need to manage the stress, but one of the ways we manage the stress is we don't put people in situations where they're under-equipped. So it's not psychiatry, it's not in the paper, but it's common sense.
But you know what? I think that kind of common sense is important. There's a great conversation. I probably quoted this about a year ago, but one of my colleagues, Patrick Lank, who's one of our assistant program directors, was doing some wellness work with our residents a while back. And he was saying, what can we do? Do you guys, like what's going to be helpful for the residents for wellness? And basically the main piece of feedback is, I don't want to have to make 4 phone calls to get a stupid lab done. And he's like, oh, ha, 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 we all have these problems. Like, seriously, though, you guys want a pizza party? They're like, no, what's going to make us well is not having to make 4 phone calls to get a lab done. And it's those kind of on-the-ground things. It's Maslow's hierarchy, to be my armchair psychologist. Pivoting, one really small minor thing that I just wanted to get your opinion on in the paper. It's so easy to, I think our brains can rationalize a lot of the trends we find in papers like this. Frontline workers having higher symptom burdens or higher risks than the second line workers makes a ton of sense. People being inside Hubei versus outside Wuhan makes a ton of sense. Things like that. One that I want to get your thoughts on, though, was that secondary versus tertiary hospitals had higher levels of depression and anxiety. Any thoughts as to why the smaller, I guess, outlying hospitals were more likely to get the higher levels of mental health burden?
So I think it's not an accident that one of the models that my colleagues who study depression in mice use to induce depression is this sort of learned helplessness, where the mouse keeps getting an electric shock regardless of what it does, and eventually just sort of stops trying. I think that the more empowered docs feel, so that the more you feel like you're in a place that's supporting you, that's giving you the resources you need, you're surrounded by a team, I think the less helpless you feel. And that helplessness is, I think, is a major concern. I think people, it contributes to depression and anxiety, and probably consequences of, when we were talking about the paper at our editorial meeting, one of the editors said, it reminds me of Camus and the plague, and sent me back to look at the plague. And the quote that's in the commentary really stuck with me, because there's a point in the quote about feeling this sense of futility. And I think that sense of futility or hopelessness, or sort of not being in a situation you can control, it might explain why the secondary versus tertiary hospitals were more affected.
Okay. Yeah, I guess that makes sense. That I guess if the secondary hospitals, they're not like the ECMO centers, they're not the big ICUs, and so they're, I guess, needing to call on others for help that also may not be there when the system's overwhelmed.
Yeah, just you can feel very far away from where you want to be.
Yeah. All right. Well, this has been fascinating. We've gone on much longer than the 10 minutes we usually do. I am a little bit late, but there's a couple people who joined. Steve Bradley, Cynthia Pina, Sivateja Tanjarala. Apologies for my mispronunciations. And also one more question. More than 3/4 of respondents were females. Could some of the findings be biased due to this? Any comments from the researchers about it?
So, I think there's lots to criticize in terms of any survey. This one definitely has its limitations. We don't really know what the denominator is. There's probably some bias based on who's concerned enough, who's willing to fill out the survey. I would say, we know that the lifetime risk of depression is substantially greater in women than men. We don't understand that sex difference per se, but it's an important one. So yeah, some of what we observe in that study may well have to do with the respondents. But again, the fact that they managed to get that kind of survey response in 4 days in the middle of a pandemic, we were willing to say, sometimes the better is the enemy of the good.
Right. One of my favorite quotes. All right. Well, again, this has been great. Really enjoyed talking to you about this. Could go on for a very long time, but unfortunately we've got some more science to talk about, and I'm sure you've got patients to get back to, I guess, for telehealth visits.
Exactly.
All right. Well, thank you for joining us, Ray.
My pleasure. Thanks.
Take care. All right. Before we move on to the other papers, a little teaser for tomorrow. There's another JAMA Live broadcast with another author interview. Let me read. It's the COVID-19 update: vaccines, herd immunity, and passive immunity. This is going to be a live Q&A with Mayo Vaccine Research Group Director Gregory Poland, MD. It's going to discuss antibody responses, the duration of immunity, herd immunity, vaccine candidates, and the prospects for using convalescence serum to passively immunize unexposed high-risk people. This is going to be, I believe, tomorrow at 1 p.m. on JAMA Live. So you can go to ja.ma/live to watch it. Also, yeah, that's interesting. I don't know, maybe, Angel, can you talk briefly about the convalescence serum? I saw some of the headlines on that, but basically it sounds, I don't know, barbaric's probably too strong of a word, but outmoded, or at least sci-fi, of taking blood from patients who have infection, and I guess either taking out the antibodies or giving the serum to patients who are sick. Any thoughts?
Yeah, so it's actually not antiquated.
Okay.
This has been done for several sort of recent infectious diseases, including Ebola, actually. And so it, has been successful in certain situations. So I think it is definitely something of interest right now. We'll see what happens.
Interesting. Sorry. Yeah, I guess that's my ignorance. This is, certainly an area, not my area of expertise. So glad to hear that it's something good. Because I mean, other stuff, I guess, when I was talking to another colleague about it, they say things, we do fecal transplants for things like C. diff, and it seems to be effective and studied. And I'm sure there's lots of other things that sound crazy that we do, but that are actually really helpful. So I don't know. Interesting. All right. You want to, so let's move on. You want to talk about our first paper on secondhand smoke?
Yeah. So this is estimated worldwide mortality attributed to secondhand tobacco smoke exposure 1990 to 2016. So this was a really interesting study. The objective was to try to calculate the number of individuals who smoke and the associated sort of number of deaths, or I should say, what the number of the individuals who smoke, how that's associated with the death of one individual who died of secondhand smoke exposure worldwide. This will make more sense when I actually talk about the results. But basically, this was a cross-sectional study. And they talk about this thing called the secondhand smoke index, which is the number of individuals who smoked for 24 years and how many of those people would be associated with the death of one individual who didn't smoke, so presumably died of secondhand smoke. And so they found that this number actually has changed favorably from 1990 to 2016. So the number that they give, which is 1990, 31 individuals who smoke would be associated with the death of one person. In 2016, it's 52 individuals, or so how they calculated. The thing that I found really interesting about the study is they actually also looked, because it was a global study, they also looked at regional variation as well. And so they saw that 42 people in the Middle East and North Africa would be required to one death in a non-smoker. And this is compared to 85 in North America. And one of the thoughts that the authors talk about in the discussion is this potentially could be related to different policy interventions, such as banning, such as in areas, for example, in North America, where smoking in public is, there are bans for smoking in public. These have been adopted. And obviously, we can't really make that determination from this study, but I think it is something interesting to think about, with the caveat being that, some of the information from here was actually taken from a questionnaire. They didn't actually directly necessarily measure, who is smoking, but still, I think sort of interesting to think about.
Yeah, this has been really interesting. Really interesting topic. The figure one shows some interesting things. Sadly, the total number of people who smoke has continued to rise, especially as some low and middle income countries. One of the paradoxes of their becoming more developed is they also adopt some of the less healthy habits and have been, I think, targeted by some profit-seeking corporations in some ways that have come out of vogue in the States or in the more developed world. And it's a little sad. Especially looking at the number of people who died, the figure 1B, that V-shaped graph, that there was a nadir around 2006 where the secondhand smoke deaths actually went down. There are some good signs. The reduction in children under 5 who died from secondhand smoking has dropped a lot, from 270,000 to 54,000. So both as a fraction or proportion as well as in absolute numbers, which is great. Obviously, it would be better if it was lower. And also the other interesting thing I found was that the average number of cigarettes smoked by smokers is down from not a huge amount, but from a little over a pack a day to a little less than a pack a day. So people who smoke. There's more people who smoke, but people who smoke a little bit less. Yeah. Yeah. And to your point about the public health interventions, one of the things that my father-in-law brings up all the time is how it's not long ago, when I was in middle school, basically, where restaurants would have a smoking section and a non-smoking section in like the same open room. Yep. But how quickly the world changed. I remember, I guess I was in college when New York and some other cities started banning smoking in bars. I was in med school when Chicago did. It's again, how quickly the world has changed.
Yeah, definitely.
All right, moving on. Speaking of changes, this is a really interesting paper. on the placebo responses among men with erectile dysfunction enrolled in PDE5 inhibitor trials. So basically, the whole idea is we know there's some level of placebo effect in all trials. That's why we do placebo-controlled trials. We don't just do the measure the potential effectiveness of an intervention. But basically, they look to quantify what the placebo effects were in the trials of medications like Viagra or Cialis. We found 63 studies from 1998 to 2018 with 12,500 men. They used the IIEF, the International Index of Erectile Dysfunction. There's always some interesting stats in studies like this. For instance, the prevalence of erectile dysfunction ranges from 6% to 64%, which is a huge range, and those wide ranges to me mean either anything or nothing. But basically, what they found is that there was an effect. So using Hedges G, which I don't know if you understand better than I do, but basically. The medications, which these medications we know are generally pretty effective. They've got some pretty good evidence, and I think there's not a lot of skepticism about their efficacy. And that the Hedges G for the medications is 1.25 on average, and for the placebo it's 0.35. And this is one of those scales where 0 would be no effect, not 1. So I think if I understand correctly, Hedges G is a fraction of the standard deviation. But basically, when you're looking across different studies, basically, if the medications work at a level of 1.25, this is about a quarter of that. And so the placebo effect is nothing. And there's some interesting talk in there about the different causes of erectile dysfunction, whether it's psychological, whether it's vascular or neuropathic or some other different things. And so it certainly is plausible. And also there's subscales of the International Index of Erectile Function. So the the sexual desire, and I forget what the other one was, scales had less of a change than the erectile function one. So makes sense.
And overall, sorry, go ahead.
Yeah, no, I was just going to say there's space validity here, so that's always nice.
And if I recall, overall, even though they did find that significant association, the effect size was small, correct?
Oh, yeah.
Right?
Yeah. I mean, 0.35 is, I believe, in a Hedges G is pretty small. Based on my little bit of learning today, if that's a third of a standard deviation, that's pretty small.
Yeah. But still something, I guess.
Yeah.
I guess so. One thing I would say is there was a lot of heterogeneity in the studies, so something to consider when you're interpreting it. But I actually thought this was a really interesting paper because we never actually. I have not come across a lot of literature that considers the placebo effect in the way that this did. So I thought that was really interesting. And I just to say, I love the first line of this paper. Few drugs have achieved the same mythologic status as sildenafil. Yeah.
It's really. It's exactly. I think sildenafil is one of those medications where it's just so interesting in so many ways as I don't know, somebody who appreciates kind of both the science and the history of science. And if I remember correctly, originally these kind of medications were being tested in heart failure. And basically, I mean, I don't know if this is true or not, but somebody once told me informally, it's probably just an urban legend that people weren't returning the pills or something like that. Or they figured it out as a positive side effect. And it's just been fascinating. It's really interesting. All right, so moving on, one more paper we're going to talk about today. So the representation of women in authorship and dissemination of analyses of physician compensation by Dr. Larson et al. This is really fascinating. It's a nice little research letter that looks at, there's a number of studies. They found, 39 of them looking at physician compensation and the gender disparities with them. And then they looked at the gender disparities in the authorships of these studies. And basically they found of these 39 studies, there were 37 unique first and last authors. I think there's a total of 148 middle authors. These were all papers 2013 and 2019. Women were first authors on 22 of these 39, and last author, senior author, in 19 of them, which is really interesting. And basically that, comparing to the 40% overall rate of women in academic medicine, in full-time academic medicine positions. there's 311 papers that cite these papers, and 64% of those had women authors. They also looked at women who disseminated them, or people who disseminated them. So just look at Twitter, basically. And of the 1,400 tweets they found disseminating these papers, 64% of the people who tweeted them were women. So overall, 56% of the women were authors and citing authors versus 40% of women in full-time academic positions. And then, so basically, not surprisingly, women have more of a vested interest in the pay disparity. I think I've certainly casually come across a lot of skepticism from men about why there's pay disparities or if there's pay disparities, which to me seems bonkers. The numbers we have, I think, are pretty convincing. And then also one last thing, that 60% of these studies had no funding whatsoever. And so kind of the burden of having to, women get paid less and then have to work basically on their own to prove that they're getting paid less and share it. And then we're surprised that women have higher rates of depression.
Yeah, no, I thought that was really interesting. And the fact that there's no authors even note in their conclusions or, that really there should be more funding avenues in this area, because there's clearly a discrepancy here. And I think that it would be very helpful to really be able to understand that more in depth. But it's hard. And then, I would say there are a lot of things in academia in which you do things that you don't end up being compensated for, but it is very difficult to do this kind of research and not have support. So I thought that was really, really interesting. The whole research letter, I think, was really fascinating and disheartening.
Yeah. Yep, exactly. And it's just frustrating. I know part of when I've heard skepticism from almost universally, I would say in my experience, universally skepticism from male colleagues about a pay disparity. It's, part of it is like, well, we don't have great evidence on it. It's like, well, we're not paying for great evidence on it. And people have to do this on their own time, and when they're already getting paid less. I don't know. It's just so frustrating to me. Sorry. Going to welcome two more people before we go. Ahmed Eltanahi and Eli Pranchovic, another one of our editors from JAMA Network Open. So welcome, Eli. Sorry, Mr. Roy, but you can go back and watch it. So thanks for joining us. We will try to keep these going. I think I'll have to go back and actually watch the video, but I think this actually worked out okay, despite us all being in geographically disparate places. So thanks for joining. We will plan on going again next week, Tuesday, the 31st at 3 p.m. Central Time. Go to the usual places, JAMA Network Open on Twitter, Facebook, and YouTube to follow us and get more of the best content. We are continuing to have papers come out every day, 10 a.m. Central Time, every weekday. So take care, be safe, wash your hands, don't touch your face, don't go out.
Thanks all, bye.